Today we have with us Professor Devi Vijay of the Behavioral Science Group of IIM Calcutta. For some time now, her research has been in the field of palliative care, which we'll be exploring through today's Insight video. So ma'am, can we start this discussion by engaging in what we actually mean by palliative care?
Sure. Thank you, Anand. My research has been in the palliative care sector in India. Specifically, I look at the palliative care movement in Kerala, and very recently I've begun to look at how the movement is diffused to other parts of the country. If you want to understand what is palliative care, the World Health Organization looks at it as any kind of care that is given to improve the quality of life of patients and their families. Patients who are confronted with life-limiting conditions such as cancer, HIV, AIDS, chronic renal conditions, chronic respiratory conditions. And so this care is not just about improving or providing medical care, strictly by medical professionals, but also some kind of social support to the family through the course of this illness. The origins of palliative care, if you were to look at it, of course, lies with advanced stages of cancer. Specifically, there was this movement in the UK during the late 1950s and the 1960s, where there was a realization that you have patients who are confronted with advanced stages of cancer, and the medical system, the prevalent medical system, was not doing anything about it. So you had patients in excruciating pain, incurable pain, and the medical system was not really addressing that issue because it's steeped in a whole treatment-centric logic. So what happens when there's no more treatment that's available for a patient? So based on these insights by practicing professionals, this whole discipline of palliative care has evolved across the world, which essentially is about managing pain relief, pain management essentially for patients. And this is also, of course, expanded into other forms of support through engagement with patients when they find that patients and their families often need emotional counseling through these kind of conditions. And of course, in recent years, with the shift in global disease burdens from communicable diseases to non-communicable diseases, something like palliative care becomes more important because we have patients who are living for much longer. So advanced stages of cancer, of course, you're probably looking at some months to maybe 2 to 3 years. But what happens when you have people who are living for maybe 20 to 30 years? What happens if you're a paraplegic? What happens if you have chronic respiratory or chronic renal conditions? And you may be living with for 20 to 30 years with a lot of discomfort. So palliative care steps in there to improve the quality of life for patients as well as the family of the patient.
Ma'am, could you give us some insight into the provision of palliative care and its global scenario currently?
So the dominant form of provision of palliative care across the world is through hospices and hospitals. So hospices, of course, the hospice movement, again, as I said, you can trace it back to UK in the 1950s and 60s. And it's essentially an institution-centric approach. So you have a team, the patient will be admitted to the hospice, and you have a team of medical professionals, including doctors, nurses, social workers, counselors, who work around the patient. Now, as you can well imagine, the biggest problem of this kind of an approach is access and affordability, right? I mean, how many such institutions can you have? How many people can afford to pay for this kind of care? Of course, you have non-profit missions which run hospices, but are they able to reach out to enough number of people? So, although the hospice movement has spread across over 150 countries, we still have, I think less than 8% of the patients who need access to palliative care actually receive it globally today.
So ma'am, where does India stand with respect to provision of palliative care for its citizens?
That's quite a depressing question actually, because so there was a study that was conducted by The Economist in 2010. It was interestingly called the Quality of Death report. And it looked at about 40 countries across the world, and India very dismally ranked in the bottom of that index. So yes, if you look at the provision of palliative care across India, it's just about 2 to 3% of the patients who need palliative care actually have access to it. And there was a research that was conducted by McDermott et al. In 2008, and they indicate that about 19 states and union territories in India had no notion of what palliative care was at all. So in that sense, it's depressing. Another complicating factor is the availability of morphine, because it's not just about the medical infrastructure being available and professionals being trained in palliative care, but also morphine is this key opioid which is used to relieve pain, and it's highly regulated in India. So even though the Narcotic and Psychotropic Substances Act was amended in 1999, state level implementation has been very varied. So while Kerala morphine is much more easily accessible, in other states in India it's still highly regulated. Morphine is not prescribed, even though we're the second largest exporter of opium, which is like the raw material for morphine, right? So I think there are many complicating factors, and because of that, however, I must add that because I study the Kerala context, the Kerala palliative care movement is very vibrant, and it's often used as a global exemplar to talk about resource-effective ways of providing palliative care. One of the biggest challenges with hospices is that it is limited in terms of access and affordability. They're so institution-centric. So you can imagine how in a country like India that becomes even more problematic, because there's a shortage of medical professionals. There is, so even when it comes to the curative aspect of it, people are not able to get access to treatment. And very often we have cancer patients who present at advanced stages of cancer. So there's in fact a dire need for palliative care. But at the same time, we are presented with these challenges, institutional challenges in terms of access to medical professionals, access to hospitals itself. So that's where we are in India.
So ma'am, could you please elaborate on the development of palliative care in Kerala?
Sure. So Kerala presents this really interesting story where it began, of course, as a doctor-led initiative in Kozhikode Medical College in Kerala. Where we had two doctors one was the head of department at that point of time at the Kozhikode Medical College, and they identified this problem. It's omnipresent if you're working in that kind of a context, where you found that there are patients who are presenting with incurable pain, and when the medical system is not able to do anything about it, they're just told to go home. So unhappy with those outcomes, they decided to provide some kind of pain relief measures, and in no time their clinic was flooded with patients. So something that they started to do was also to go to these patients' houses, because they realized that many of them came in from remote areas, they had difficulty traveling, they often traveled with a bystander, which meant that that person was losing out on a daily wage maybe. So these doctors started traveling to these neighboring areas where they also had some kind of local volunteer support. So eventually, somewhere around 1998 in Kerala, this became a community movement, where the community was involved in terms of organizing these clinics in local remote areas. And the doctors would just come in, look at the patients and go back. Now, interestingly, what happens with the community's involvement is they don't see symptoms, they see suffering, right? So when the doctors begin to look at only advanced stages of cancer, the community thinks that, well, why should a paraplegic patient not be looked at? He's also bedridden, he also is isolated, he also has suffering. He's for long days he's sitting in his house, he's isolated, needs attention. So the community started bringing in all these other categories of patients. So eventually by around 2003, 2004, you see in Kerala that there are chronic renal conditions coming in. You have geriatric patients who are brought in for palliative care. So a lot of elderly people left alone at home. The rest of the family may be outside the country or in other parts of the country itself, but not being able to care for older patients at home. So that's why the community started getting involved and spending more time with patients so that they don't feel isolated. Sometimes supporting the family if they find that the family doesn't have money to buy medicines or even food for their daily subsistence. So that's something which the community gained insights that this is something that the medical professional cannot do. And in fact, this is a larger problem which the patient has. So they articulated that 80% of the patient's problems are social and only 20% of the problem is medical. So that transformed the way this movement started organizing. So the pivot, the central aspect of the movement was about the community being the locus of caregiving, decision making and so on. And the medical professionals coming in only as and when required to provide whatever basic care is required for the patients and their families. So I think that change in frame was very important, that transition from medical care to talking about social issues and community-based care. And there are about 200 organizations in Kerala today across all 14 districts of Kerala that provide care to more than 60% of the patients. So as I said earlier, that only 2% of patients in India get care. That's when this case becomes so stark, right? And so important to understand that how is it that the community managed to gain this much of scale as well as scope of organizing. The other important aspect of this is that all the funds are locally raised. So there are no big donations that come in, but it could be 1 rupee from the bus driver, it could be 1 rupee from an auto driver. So it becomes a truly community-owned movement.
So ma'am, has the government played any significant role in encouraging the development of palliative care in Kerala?
Yeah, I think that's a great question because especially in the early years, of course, it was completely community-driven. But in 2008, there was a landmark policy which was issued by the Kerala state government. And there they say that, among other things, that all primary health centers have to be equipped with palliative care equipment, with the doctors and nurses need to be trained in palliative care. What's also important is that they recognize the role of the community-based organizations, and they kind of mandate that the community organizations should work in collaboration with the primary health centers, therefore legitimizing the role of these community organizations in provision of care for patients and their families. But even after that, the National Rural Health Mission, for instance, did play an important role in terms of sending doctors and nurses to work with a lot of these community organizations, especially in remote areas, in the provision of palliative care. So in that sense, yes, maybe the entry has been late into the provision of palliative care, but it's definitely been supportive.
Ma'am, is the Kerala model replicable in other places?
So indeed, yes. That's something that there's an active attempt to replicate Kerala and other parts of the country. In fact, we have an initiative in West Bengal itself where the district administration in Nadia has been attempting to replicate this community-based model since last year. So from July 2014, there have been attempts to train volunteers. The Sanjeevani Palliative Care Society was set up in September 2014, and it's been running very vibrantly. The provision of services have diffused to about 25 different gram panchayats in and around Krishnanagar. However, I think the problem remains that very different institutional contexts. If you look at the health infrastructure in Kerala versus the health infrastructure in West Bengal. So these are challenges that come up as the implementation is on, and we learn from it. So these are experiments that are on. There have been attempts, of course, to replicate the Kerala model outside India as well. In fact, some of the doctors who've been involved in the Kerala model from the earliest days, they're working very actively to diffuse the Kerala model in other countries. For instance, I'm aware of initiatives in Thailand, in Sri Lanka. Bangladesh was one of the earliest to try and learn about the community-based palliative care model. So there are definitely attempts to replicate it. It's a very resource-effective model, as I mentioned, and also simply by virtue of the community's involvement, it also becomes a great form of support for the patient and the family at home, right? Which is another insight that we have from the palliative care field, which is people do prefer to spend their days, especially your dying days, in your home and not in a medical institution. So that's something which a community-based model has been very effectively able to do, and another crucial reason to look at diffusing it even further.
Ma'am, finally, could you touch upon the challenges faced in replicating this model in other parts of India?
So I think it's important to underline the fact that there are independent measures being taken for palliative care in India, and some of them are really robust models. So for instance, you have Can Support, which is run in Delhi, again providing palliative care largely oriented around cancer patients. You also have work which is run by Tata Memorial Hospital in Mumbai. There's Karunashraya in Bangalore. So these are definitely independent, robust efforts across the country in terms of provision of palliative care. I think the challenges that we face are also linked to this because they remain institution-centric. So how do we make this more accessible to the masses? in terms of scale and scope of provision of palliative care. The second issue I think that I would think about is awareness. That awareness among both the general society in terms of who is a patient who should get palliative care, when should palliative care begin. These are ideas that we should have as a larger society. That when should a patient get palliative care, for instance. And the second is, of course, awareness among medical professionals about what palliative care is and how it must be provided not just in the later stages of an illness like cancer, but also at the onset of diagnosis itself. And it is because often there are myths associated with palliative care. There's in a treatment-centric logic, one can confuse palliative care with just giving up, with not prolonging treatment for a patient who's deserving of care. So, but palliative care isn't about giving up on a patient. It is about improving the recognizing that a patient has the right to a quality of life, and it is about improving that quality of life for whatever days that he or she has left. So these kind of myths need to be clarified, that it's not about giving up on a patient, it is not about stopping the treatment. It's actually a complementary approach to, it can be provided at the onset of disease itself when when the conditions are diagnosed. So I think awareness among medical professionals is also crucial to the provision and greater reach of palliative care.
Thank you, ma'am, for sharing your valuable ideas on this pressing issue, and we'll be back with our next insight.